All right, so we are here. We are in our last session of our PN2 lectures, and so I thank everyone who's been able to join me this morning, and those of you who are joining through the recording. Hopefully, you're making time in your week to listen to this. I try to draw your attention to some key concepts that help you to prepare for your exams and for practice. So I'm going to share my screen so you can see the presentation. Okay. And so as always, we start with some announcements. So just as a reminder, written assignments this week are not accepted late. So normally written assignments, you can turn them in up to a week late with a 10% deduction for each day that it's late. But during week 10, I want to have everything graded for you by Monday so that as you're preparing and going into your final exam, you know exactly where you sit. And right now, I believe everything is graded except that week 10 written assignment, and then if you'll have a quiz that's due Sunday at midnight. I noticed some people have completed it, but it's not due till midnight Sunday, so you have until then to get that done. But I believe those are the two outstanding assignments for the quarter. Remember that our final exam time is going to be Thursday, a week from today, at 10 o'clock. So the window will be open from 10 to 12:30, and be sure that you are starting the exam at 10 o'clock. Don't wait till 11. It's important that you have that full 2 hours to take your exam. It is a 100-question exam, 10% SATAs, so that means there will be 10 SATA questions. There are 4 dose calculations on it, so double of what we do in a regular exam. Also know that 30% of that exam is from modules 9 and 10, and the remainder of it are from the previous modules that we've covered. Your review guide is out there. I actually released that a couple days early. I just felt that extra time might be a good thing. So I put that out there a little earlier for you. So hopefully use that to guide your study of the concepts. And then I am going to have a final exam review tomorrow. So we're going to do it from 9 to 11 tomorrow. It's interactive. I'm going to be asking you to chat in. I usually do a Family Feud kind of activity where we do the review during class and we break up into teams, and it's really fun. Unfortunately, the online environment doesn't really lend well to the Family Feud, so we'll have some adaptations for that. We're not going to break into teams, but I want you to interact with me. I have decided to record it. I'm not sure I will next quarter. I haven't in the past. I've been debating back and forth about it. Some of my colleagues record, some do not, and I just made the decision this quarter I'm going to record it. So I hope you'll participate, because it's no fun for me to do it on my own with nobody interacting, but it will be available for those of you who have to work and have other commitments that you weren't able to free up to attend it. Remember that your dose calculation exam will be coming up during week 1 of next quarter. It's not the exact same dose calculations, but they will be very similar. The setup will be similar. You have to pass it at 100%. Nobody's handing it back to you and say, hey, take a look at this. And our leadership has been very clear that the exception that they made last quarter, allowing remediation instead of being withdrawn from the class, will not happen this quarter. They've been pretty strong about that, and they want us to make sure everyone understands. So please, please, please take the time to do some practicing over break on your dose calculation, especially if you know you're someone who struggles with it. Take your time when you do your dose calculation. You've got, I forget how long we allow for it. It slips my mind. I have it written down somewhere, but not here next to me. But, go through, do the dose calculation, and then go through a second time and redo it without looking at your answers. And if the 2 answers that you come up with don't match, that's a sign that's one of those you've made an error. So that gives you some time to double check it. My understanding is that you can move back and forth through the questions. That's how I have always set it up. I will not be setting up yours for next quarter. For most of you, I'm hoping all of you, hopefully all of you will move on to PN3 and role and scope and leadership. But I have it set so you can move back and forth. So you might want to ask that of whoever is administering your exam, just so you know that. I think last quarter some students didn't know that, and so they might have gone back and checked. So I just want you to be aware of that because I want to give you the best opportunity to be successful with it. There's Connect with Tutor Match this week if you need to. If you need someone to tutor you, reach out through the library services. They can pair you up with someone who is strong in dose calculation, and maybe you can find some time over break to work with them. So, and there's lots of resources out there for you as well in the library, as well as some that I have sent in the past. So if you look through things I've sent, you should be able to find them. And let me know if you have any questions about that. Office hours on Monday. So normally I'm like 9 to noon, but I know you have a 2-hour final exam during that time. So I did extend mine to 1 o'clock. So if you need to meet with me, email me to set up a time. I probably will be sitting here working. I've got a ton to do to finish up and to get ready for next quarter, but I want to make sure that I don't have a couple students coming at the same time to meet with me. So let me know if you need that. And then my last announcement has to do with your clinical evals. If you have not, has anyone not received their final clinical eval from their clinical instructor? Is there anyone in this group?
I have not. I have Chandra.
Okay, thank you. That's helpful. I will reach out and make sure those get sent to you. So be looking for those if you haven't received it already, and make sure that you sign it and get it back to your instructor. So I will reach out and make sure we get those to you in time so you can finish those. And so if you haven't received it, be looking for it. If you have received it, make sure you review it, sign it, leave comments if you'd like, send it back to your clinical instructor. And you can schedule a meeting to meet with your clinical instructors if you would like to meet in person, well, over WebEx, to discuss it. So, and of course, if you have me, you know that I've been open to that all along. So get those back in. I've got quite a few of them, but not all of them for my clinical people. So I'll be sending one reminder, but if you don't return them, you can fail clinical. And I don't want that to happen. You've worked too hard to not pass the course because you didn't turn in an evaluation form that was asked of you. Okay, any questions about any of those announcements before we move on to the content? Ron, when have I reviewed and approved these? What are these? Are you talking about clinical evals?
No, the dose calculations. So there aren't any misleading ones.
Well, I will tell you that one question that Ron, you and I had a lot of conversation around at the beginning of the quarter, I didn't get the resolution I had hoped for from my local leadership. Just they had taken it up the chain, but they hadn't got a resolution. And I actually went right to the top with it and had a scheduled meeting with someone and brought it to their attention. And they are, at least that particular question, they are revising it. And the individual I met with had plans to review all of the dose calculations for similar type questions to clear up that confusion in how they worded that question.
Awesome. Thank you.
So absolutely. And I'll be honest, if you're with me and we have a question like that, I'm fighting hard next time because, well, you know why. I wasn't happy about the resolution I got from that. But at least nobody missed the quarter because of it. And so I had to resign to that because we had to move forward. But next quarter, if something like that were to happen, there's the chance that somebody could have to sit the quarter out. And I'm not okay with that when we have an opportunity to improve our assessment. So I will be fighting probably a little more assertively. Fighting is the wrong word. I will be advocating a little more assertively if something like that happens again this next
I appreciate
quarter.
you. Thank you.
You're welcome. All right. Any other questions? And no, Ron, I haven't seen the other exams, so I don't even know what's on it. I only know the one I have to proctor. Okay, so let's move on. And so body mass index calculation, it's important to know how to calculate this. There's a couple formulas, whether we're weighing people in kilograms and pounds. And one of the activities that I like to do, and I know students just absolutely love this, is I want you to take a minute and I want you to calculate your BMI. Now, we've got these formulas here, but don't use those. Google, if you just do a quick Google for BMX or BMI calculator, you can find an easy way to do that. So I want you to just take a minute and open a separate screen or use it on your phone, and I want you to calculate your BMI. No one's reporting it. So we may have some conversation around it, but nobody has to report what their BMI is.
I've always had a huge issue with BMI because I am a thick person, thick bones, thick muscles, and I am morbidly obese on that scale. And I could be 10% body fat, doesn't matter.
Yeah,
It doesn't account for the fact that you weight lift.
Yes, or just how your bones are structured. I have 3 sons that I gave birth to. I got to raise another son and 2 other daughters. And my oldest son is 6'4". His dad is like an inch shorter than me. I'm about 5'6". I'm not sure where 6'4" came from. we joke, but he truly is genetically both ours. And he's 6'4", and he has long, lean muscles, but really muscular. Like he could be a model kind of muscle structure. My youngest son is about 5. I think he reports 5'10". I think he's about 5'9", and he is bigger boned, and and like you mentioned, a thicker muscle mass, and so they can end up with having the same BMI, and they weigh the same. There's 6 inches difference between them, and they weigh the same, and neither one has an ounce of fat on them. So yeah, what muscle does weigh more. So the BMI, and we'll talk about that. I know I talk about it in the recorded lecture, but we can just, well, let's move forward. So we'll talk about it when we get to the next part. What is our normal range for BMI? Anybody you can unmute or chat in, whichever you prefer.
18.5 to 24.9 is normal.
Yes, exactly. So we've got this 18.5 to 24.9. So I'm going to just move to our little slide here so we can talk about it. So, when we're talking about what's normal BMI, if someone, we can't just say less than 24.9 or less than 18.5, excuse me, because less than 18.5 is not a healthy BMI either. And there are plenty of people who fall below that. And there's just as much danger in having that low BMI as there is having a high BMI. They use this standard just because it's easy to calculate, but there are lots of other standards. In fact, the hip waist ratio, it's in the recorded lecture. That's actually a more accurate indicator of how somebody's weight can impact their health. It's a higher indicator of the risk for diabetes and heart disease when people are off with the hip to waist ratio. So take a look at that. I didn't put it in here for us to talk about, but just like Ron mentioned, just depending on how you're built, that can have a huge impact on that. And women, we are shaped so very different. Our bone structures through our hips. My very best friend, we joke. She's an apple, I'm a pear. My hips are wider. We wear the same size, and yet we can't wear the same clothes because of how our body shapes are different. And so there's different risk factors with that, depending where people store their excess fat. Um, and as I look at these levels, I want to point out, 18.5 to 24.9 is the normal weight. And when you see someone who is 25 to 29, they're actually considered overweight. And they may actually not be overweight. So as we mentioned, you have to look at all of these factors in that. When you see someone who is 30 to 39, they're most likely have some excess, not everyone, as Ron shared with us that, he classifies even though he's perhaps not overweight. But think about if you're not someone who has struggled with maintaining your weight, it's easy to say, well, why don't these people who are 30 to 39, they're obese. This is a harsh word. When we hear obese, when I hear obese, because I fall into this category, at least I did before COVID started. I actually have lost a little weight since then, but I'm not even sure where I am right now. I should have recalculated. But I normally, 6 months ago, I fell into this category of being obese. It's hard to hear that. It's hard to see that in your medical record. And these people didn't just like sit down and eat the store out of cookies one day to get to this BMI. Often what happened is at one point they were in this normal range, and perhaps they gained a little weight and then they lost it, and then they gained a little bit back and they were a little higher in this just overweight category, and then they did something about it, they lost that weight, but then they gained it back, and then suddenly they're in this obese category. And honestly, that's the story of my life and lots of people I know who fall into this category of being either overweight or obese. They didn't just they weren't born that way. They didn't just get there and give up and stay there. It's a yo-yo effect, which is really unhealthy for people. But it's a battle, and it's an emotional battle. It's hard for these individuals to wrap their brain around making the lifestyle changes that stick, that are permanent. And so, working with them to find what motivates them, encouraging them is super important. When you see individuals who are this greater than 40 and they're considered morbidly obese, often there's something metabolic happening with them. It's not just an overeating problem that is as much emotional as it is physical. There's usually some kind of metabolic thing going on. I've taken care of patients who have been 900 pounds. I've taken care of patients who are 700 pounds and could walk around just fine. And, they had a lot going on. They had a lot of health issues because of this, but they were still mobile. And, one of the individuals I took care of who was over 900 pounds was probably one of the nicest people and one of my favorite patients that I ever cared for. He just had a positive attitude. He wanted to make changes. It just life and his metabolism and stresses got away from him, and he didn't get the help he needed early on in order to prevent him from getting to that point. Katrina, yep, having kids and a broken thyroid makes you fat. Yes, it does. I am the poster child for that. All right, so just want to point that out to you. Be compassionate to those people who fall in these higher categories of overweight, obese, and morbidly obese, and figure out what we can do to support them and motivate them, because it's not, they didn't just get there overnight. It's not a quick fix. And it truly is hard for people who don't struggle with that to know. Likewise, I have a friend who probably has a less than 18.5 BMI, and that lady cannot gain weight to save her life. She is eating all healthy stuff, proteins, and cannot seem to, she wants to put on like 10 pounds in the right places and just can't seem to do it. I can't relate to that at all, but I understand that her struggle is just as real as mine. All right. So let's talk a little bit about hyperthyroidism. So chat in privately to me some of the clinical manifestations of hyperthyroidism. Just want to get you thinking, engage your brain a little. Okay, so we've got somebody said colder, insomnia, anorexia, weight loss, fatigue, easier. So I'll go over all the correct ones. I'm just reading through what's coming in for me. So don't write all of them down. Possibly diarrhea. Okay, good. Okay, so anxiety and irritability. Usually these individuals, their heart rate is a little faster, so they have some tachycardia, and that causes some anxiety and irritability. We sometimes see fine tremors of the hands and fingers. There's heat sensitivity and an increase in perspiration, or they might have warm and moist skin. So as somebody chatted in, hyper is warmer. So yeah, typically they are feeling warmer at times. We do see weight loss despite normal eating habits. So it's not just that they're not eating. So anorexia probably isn't a good description of it, because they usually are eating normal amounts of food, but they're losing weight despite that. Enlargement of the thyroid gland, that's called a goiter. So you can often see that in the neck. If you have them lift their chin and swallow, you can often see that stick out. For women, you'll see a change in menstrual cycles. For men, possibly erectile dysfunction. For both genders, reduced libido, diarrhea or frequent bowel movements. The classic sign that we see is called Graves' ophthalmopathy. Wow, that I had trouble getting that out there. So, and that's those bulging eyes that we often see. That's pretty classic. Thick red skin, often on the shins or the tops of the feet. That is called Graves' dermopathy. As I mentioned, we might see rapid or irregular heartbeats, so some tachycardia and some palpitations with that. As far as labs go, what we're going to see is a low TSH and a high T4. And that's important for you to know. Low TH and high T4. So if you didn't know how, I'm sorry, that's TSH, not TH. I tripped over that. So if you need a refresher, I'm going to give just a quick refresher on how the TSH lab levels work and why we have low with hyper. So our brain is constantly scanning enzymes in our blood and looking for abnormalities. And so when it notices that there's not enough thyroid hormone, it will actually produce a thyroid stimulating hormone that travels to the thyroid and is intended to make the thyroid produce more of the thyroid hormone. And so when someone has too high levels of thyroid hormone in their system, the brain is going to make less. It's going to send less of that hormone. And so we're going to see low TSH or thyroid stimulating hormone levels. And you'll see the opposite with hypothyroidism. So that explains that. All right, so what are we going to do?
We need to know the exact levels, like, or just know that it's like, what are the regular levels?
So your regular levels, that's a good question. I want to make sure I give you the right ones because I get my labs checked and I know what mine are with my lab. But I want to make sure I give you the correct ones. So your TSH for our Rasmussen lab levels are 0.4 to 5.5. Your T3 levels are 80 to 180, and your T4 is 5 to 11. So 0.4 to 5.5 for the TSH. T3 is 80 to 180, and T4 is 5 to 11.
Thank you.
You're welcome. Yeah, and that's not too far off. Usually I say 0.4 to 4 is what I'm looking for my personal TSH level. I've been taking supplements. I have hypothyroidism for almost 20 years now. So, all right. So what are we going to do? What about this hyperthyroidism. So what interventions are we going to look at? So go ahead. You can chat in privately, or actually, I don't care if you chat into everyone. It's fine. Let's talk about some of the interventions. So someone's thyroid's overworking.
Are offering frequent high calorie meals.
Yeah, good. Very good. Okay, so we're always educating on the medication regimen that is prescribed for them. Yeah, so sometimes we give them radioactive stuff to actually kill some of the thyroid, especially in Graves' disease. And I'm sorry, I thought my phone was turned off. It keeps dinging here. So we give them radioactive treatment to kill some of those cells that are overactive. Yeah, we're going to monitor those. They're going to lifelong, they're going to be monitoring their levels. Weigh them daily. Absolutely. Somebody put that in there. We want to weigh daily because if they're losing weight, then they might want to let their doctor know about that, or perhaps they have to adjust their diet. If their levels are okay, but they're still losing weight, they might need to do that. All right, so I'm going to jump to our next slide. Thank you for interacting. Oh, adjust the room temperature. Yes, if they're hot all the time, they may just need to have their house colder, which gets tricky when there are multiple people living in the house to find a temperature that makes everybody happy. All right. So as we mentioned, the frequent high-calorie meals, we're medicating for the diarrhea if that seems to be a problem, a fan or decreasing the temperature, daily weights. So the propyl thiouracil, or PTU, is a medication that can be given, and it is safe for pregnant and breastfeeding women. Okay. The radioactive iodine and the methimazole are not safe for women who are pregnant. So it's important to know the difference between these two. A lot of times they'll do a thyroidectomy. So they'll take the thyroid completely out. And we're seeing, I don't know if those of you who are working in healthcare are seeing this, but I have seen an increase in the number of women who actually have thyroid cancer. I've seen some documentation that is possibly attributing it to the x-rays that are being done. And, we put the lead plate, the lead vest or whatever over the ovaries, but we don't put it over the thyroid, over the neck. They don't cover that. And so they're seeing a lot of young women, women in their 30s, early 40s who are getting thyroid cancer. And so in this case also, they end up with this hyperactive thyroid thing. And so they might take that thyroid out. When we take the thyroid, it is scary. Yeah. So when they take the thyroid out, then they are no longer have the ability to make the thyroid hormone. So then we have to replace it for life. So somebody could start out as hyperthyroidism and then eventually become hypothyroidism and have to have it replaced. Okay, so thank you, Echo. I'll let you read what Echo put in there. Yeah, there's sometimes they take, if it's not cancerous, they may just take part of the thyroid and leave some of it so that the body can still produce the hormone, but sometimes they have to take the whole thing out. It depends on what's happening with it.
Yeah, my mom had similar. She had half taken out, but then the other half compensated so she doesn't have to take anything.
Yeah, and that's the ideal situation for someone with hyperthyroidism. Let's get part of it out and find that perfect balance. But depending on what's causing it, they might have to take the whole thing. So it just, each patient's a little different. And then, if the parathyroid is damaged during the surgery, they may actually need some calcium replacement for that as well. So that's important to keep in mind. Just want to make sure I covered everything on my notes here. So when they've had thyroid surgery, these individuals often end up in the ICU because there's a risk of a thyroid storm that can happen post-surgery. It's kind of this weird thing, but they can have a storm, which can be life-threatening for them. Their blood pressure and heart rate are impacted by it. They become very tachycardic. And so, they often are monitored in an ICU for at least overnight after their surgery, just to make sure that they remain stable. And they also, after surgery, pain medication, they do have pain. So we have to make sure we're treating them for that. All right. Any questions about hyperthyroidism? Okay. Then we will move on. Let's talk about some of the clinical manifestations of hypothyroidism. So chat in or unmute and share.
You're always tired, you're cold.
Yeah, sensitivity to cold, cold a lot. Weight gain, not always weight gain, but it's pretty common. The weight gain's pretty common side effect. Yeah. So my youngest son was 16 and in high school at the time. I almost said college. He was in high school at the time. And he came home one day and he was so excited. He was old enough to finally donate blood, and he donated blood. So he was super proud. And he's like, Mom, I got to donate blood. And he hands me this little flyer that they gave him. And it's the flyer that if you've donated blood, they always put your vital signs on it, and it's informative about what's going on and what you should do after you donate. And he was super, super excited about it. And he left it on the counter, and I was fixing dinner. And later on, I looked at it, and I looked at his vital signs, and his heart rate was like 44, something like that. And I'm like, oh, Jacob, are these your vital signs? He's like, yeah, why? I'm like, they let you donate with a heart rate of 44? And he said, yeah, why? And I'm like, that is not normal. You are not a runner. He's a football player. He's a sprinter. He's my dense, compact kid, and so, he is not a distance runner at all. And so I, of course, the next morning called the doctor, and our family practice doctor, whose office is like a half a mile from my house, and said, Jacob had this going on. Do you think you could fit him in the next day or two? And they're like, yeah, sure, we can get him in. So, and I said, well, while you have him in there, will you do an EKG on him, and you check his TSH level, because we nurses like to tell the doctor's offices, how to do their job because we think we know better. And so I just make fun of myself about that. But so they did. And his TSH level was 20 at that point. And when we look back, the signs were there. Somebody just chatted in that we see depression with it. It was springtime when this happened, and he'd been in a funk half the winter, had some other family stuff issues going on because of that. And but he didn't gain any weight or anything, and if it hadn't been for the vital sign, we never would have found it. And so most people are on about anywhere from like 75 to 150 micrograms of Synthroid or levothyroxine to treat this. He takes 250 a day, and he has had the hardest time regulating his thyroid level. It almost kept him out of the career. He was looking at going to West Point. He did end up going, but we had to jump through a ton of hoops with medical exams to get him approved. And then while he was there, he was getting his medical clearance for flight school, and his thyroid was off again. Anyway, it was a huge ordeal. So, I tell everybody that because if you have a patient who comes in and they happen to have a really low heart rate and you can't explain it, like they're not a marathon runner, they're not on a beta blocker or DIG, look and see if anyone's done a TSH on them and ask the provider to run that. I have caught like 2 patients in the hospital who were hypothyroidism because of this experience. So I just share that because not everyone has the classic signs, but a lot of you have chatted in a lot of the very classic signs. So I'm going to read my list to you so you have them all. There's fatigue, weakness, weight gain, or increased difficulty actually losing weight, coarse, dry hair, dry, rough, pale skin, Hair loss. Hair loss is very common with it. The cold intolerance. Bradycardia, as I mentioned, muscle cramps and frequent muscle aches, constipation, depression, irritability. So you can get irritability with both hypo and hyper. Memory loss. So, I could blame my memory issues on my midlife brain or my hypothyroidism. I have both options to blame. I refuse to say it's early dementia. It's not. I'm just being silly. So abnormal menstrual cycles, decreased libido, and then for our labs, typically we're going to see a low T4 with a high TSH. So again, the TSH is inverse. So if you have low thyroid function, you're going to have a high TSH because the brain is trying to get the thyroid to produce more thyroid hormone, so it sends more of the thyroid stimulating hormone. So hopefully that helps you understand that process. All right, questions about the clinical manifestations? Okay, so what are we going to do about this hypothyroidism for our patient? What interventions are we going to be looking at?
Medications.
Yeah. Yep, the big thing is medications. So, we're monitoring these levels and we have to, especially with someone with a new diagnosis, we're going to be monitoring them very regularly. So we're giving hormones. So the thyroid, the Synthroid or the levothyroxine, or Armour makes a brand of thyroid replacement as well. They are actual hormones, and this is for life. For most people, this doesn't go away. A lot of people, I see increased iodine intake. So for people who have just a mild hypothyroidism, often that addition of the iodine is enough to correct it. I have a good friend who is able to manage hers just with an increase in some iodine supplements she takes. Her sister, not so much, and me, not so much. I needed the actual levothyroxine. So important education about taking the levothyroxine. So it takes a while to get to a therapeutic level. It's not like a blood pressure, a beta blocker, where you give it and it has its effect and it wears off. This is a medication that builds up in you, it's a hormone, not a medication, that builds up in your system over time. And so, we usually don't, they usually will, as they're adjusting the dose, they'll check the levels every 4 to 6 weeks. It just depends on the doctor until we get them at a therapeutic level. Then we'll have a couple serial checks to make sure they're maintaining it at that level. And then we can usually go to every 6 months, or as long as I've been on it. And I know my signs when I'm not therapeutic. And so I'll call the doctor and say, hey, we should probably check this. My heart rate normally is in the 50s, and I am not a runner, in case you couldn't guess that already. And so when I drop to the 40s, then I know that my thyroid levels are off. And so I'll just let the doctor know that, even though it's not time for my annual checkup, and we'll check it. And if need be, we adjust it. So it takes a while to get to that level. Now, if you read the instructions, let's see, I've got somebody. There we go. If you read the instructions in your drug guides on giving this, it tells you to give it on an empty stomach. And it's best absorbed on an empty stomach. Now we know that, and yet if you're working long-term care, my guess is you're not giving your patients their Synthroid or levothyroxine on an empty stomach or alone. You're probably giving it with other meds or even with meals. You're supposed to give it 30 to 60 minutes before the meal. So calcium blocks absorption. So we really need to be careful around calcium with this. Very important. But even if we're adjusting the doses for each individual to get them to a therapeutic level. So if every day they take it with breakfast, you can adjust their dose. They end up needing a higher dose for it, but you can adjust it to get to the therapeutic level, giving it that way. And so I think that's why, just because if you've worked long-term care, you know it's absolutely ridiculous that you're going to do, 3 different med passes in the morning to, your 30 residents that you're responsible to pass those meds. And so the doctors know that, and so they'll just work with the staff to monitor those levels and adjust the dose accordingly. So, but just know that the recommended way is on an empty stomach alone with nothing to eat for 30 to 60 minutes after they've taken it. It's best absorbed. The endocrinologist that my son went to, he told us a story of a young man. It was an adolescent even. He wasn't even a teenager. In his church that ended up having Hashimoto's disease, which led to the hypothyroidism. And his family, he didn't have a really strong family, and they were not reliable to get him his thyroid medicine every day. And so the doctor would bring it to church every Sunday and give him his whole weeks. He would take it all at once, and they were able to get therapeutic with that. So I'm not sure that's the best. I would think there would be some storms, you'd feel some increase that first day, but he was able to get to therapeutic levels with it, and so that worked. Yeah, so I had just had somebody chat in that they worked at a facility where third shift gave the Synthroid at 5 a.m. So the night shift nurses they actually woke the individuals up in the middle of the night to give it. And actually my son sets an alarm to get up in the middle of the night to give it, because he's in the Army and he has to eat early because they have all their training like at 5:30 in the morning, and he can't wait to eat when he gets up. So he was having trouble getting therapeutic levels, so he started setting an alarm for that purpose as well. So people do what they have to do to manage it well. All right. Let me see if there's anything else I wanted to. People usually see a slight change or improvement in their symptoms in 1 to 2 weeks, but it often takes months for them to actually feel better. And, even once you get to a therapeutic level, these individuals don't necessarily, all their symptoms don't go away with a hypothyroidism. Even controlled, they're going to feel cold. They're going to struggle with weight management. They may have some bradycardia still with that, and some of the other depression, libido issues, constipation, all of those can continue even once you get them to a therapeutic level. So questions about, or comments, or any interesting facts that you want to share about hypothyroidism, any of your experiences, personal or professional? All right, I'm not seeing anything coming through. Don't switch brands. Thank you for bringing that up. So some people, it's important not to switch brands, because even though each dose from different manufacturers can be formulated just a little bit different. So once you get therapeutic on a certain brand, you need to stick with that brand. Now you don't always have control at the pharmacy if you're using the generic, the levothyroxine, because they may, because of purchasing agreements, may switch the manufacturers of it. So a lot of the doctors will insist that their patients take the Synthroid brand because it's consistent and it's from one manufacturer that has that trademark for Synthroid. It ends up costing more with co-pays and for insurance. But to get that level, that's important for people who, especially those who are have trouble regulating. So thank you, Yvonne, for sharing that, reminding me to draw that to people's attention.
I have kind of a weird situation. I have a autoimmune disease, and I kept telling my doctors that every time I took my Levo, that I would have flare-ups every day. So they switched me to Synthroid. So Synthroid is the brand name, if nobody knows. And I was still having flare-ups, but they weren't as bad. I ran out of Synthroid one day and took one of my Levos and had a huge flare up. So I told 4 different doctors that my thyroid medicine is giving me flare-ups with my autoimmune. I was told by 4 doctors I was crazy and it was just a hormone replacement. And I finally found a doctor that put me on Armour Thyroid.
Yep.
So for some people that have autoimmune, sometimes the Synthroid and the Levo can cause a flare-up in your autoimmune.
Yeah. And that makes sense. And sometimes it's not the hormone itself that's causing it, it's what they have it suspended in. It's what makes up the pill for some people, but it could actually be because the levothyroxine and the Synthroid are synthetically produced. The Armour, I believe, is it pig?
Yeah, it's pig hormone. Yeah, it is. It's
Pig
something
hormone.
we found out that the one doctor that actually took the time. It's however they produce the synthetic, the base of it, how they produce it. My body just reacted to it. It's actually common with a lot of people that have the undifferentiated connective tissue disease. That
Interesting.
it's common. Yeah, it was a lot of doctors to figure it out, but it was a mystery for like 5 years of people telling me I was crazy.
Yeah, and that's hard because when you take it and you have that reaction, there's truth to it, that there's evidence. And to get someone to hear you, that can be a challenge. So that's a lesson to us to be listening to our patients and advocate for them when they are insistent about how something is affecting them. So excellent. All right, so that's the meat of what we're going over during the live lecture today. So let me get to my last slide here. Just as a reminder, we've got the exam review tomorrow morning. I am going to record it for those of you who can't attend or those who want to re-listen to it. That was the biggest reason, was in case somebody wanted to re-listen to it. What questions do you have for me as we finish up here? Whether it's related to this module or just general questions.
Can you tell us a little bit about a thyroid storm?
Yeah, a thyroid storm happens when the thyroid sends this surge of the thyroid hormone through the body, and so what we see, they often will run a little bit of a fever. We'll see tachycardia. So that's usually our first sign with someone. We're watching their heart rate when they're in the ICU, and you'll see a spike in their heart rate. You might see a spike in their blood pressure, and it can be an emergency. So they may have to actually give them some of the medications we give, the methimazole or the PTU, while they're recovering from the surgery to get it. And it's pretty intense. They're going to be your individual is going to feel very anxious, and they're going to know that something's wrong, but they may not be able to identify that it's just their heart rate. We're going to see the heart rate going up, but they will have this impending sense of anxiety and anxiousness, and it's very scary. It's very scary and very intense for people who go through it. So we monitor very closely after they have part of their thyroid removed, because the thyroid can't respond that way. Does that answer your question?
Yes, thank you.
You're very welcome. So I have someone who chatted in, is PN3 this hard? Yes, PN3 is this hard. It doesn't get easier. Every course gets a little harder, little harder, little harder. What I can tell you is that most students, once they have successfully completed PN2, they have usually figured out how to prepare differently than maybe they were doing before, and they figure out how to navigate the exam questions. And so if you haven't I've been trying to send messages out for people to complete the test question dissection yes resource that's in supplemental course documents. There's a video, there's a PowerPoint for you, but there's an actual recording of the author of the PowerPoint going over it with an actual student and walking you through it. And it takes about an hour. And I sat through it the beginning of this quarter. I had recommended it. It came to me in the middle of last quarter. It was shared with me and I gave it to students, but I wanted to really understand what they were getting at. And it is phenomenal. I'm actually going to use it in my first class. I'm going to be using her PowerPoint, not her recording, but I'm going to use her PowerPoint and actually teach it in the class because I think it's that important. There's a 4-step process she teaches about that teaches you how to look at the exam question and really understand what it's asking and then evaluate each of the options in the multiple choice questions or the SATA questions, and really, really helpful. So if you haven't listened to that or participated in that and you're struggling, I encourage you to do it, but then don't just watch it and say, oh, that's nice. Take those steps and practice with NCLEX style questions, whether you're using the ones I put in each module or there's the e-textbook that's out there for you in Blackboard that has test questions or practice ATI questions, whatever you practice with. It'll get faster as you do the 4-step process. It'll become intuitive to you. And I think it'll make a huge difference if you're a student who's struggling to navigate those questions. And even if you aren't, there's benefit to it. So PN3, same type of exam questions you're going to see and same workload. It's intense. There's a lot to get done. You're going to be covering new concepts, a few reviews. Your cardiac, you're going to take the cardiac information you learned in this class, but then you're going to build upon it. You're going to work with cardiac rhythm interpretations. You'll learn about burns. You'll learn more about cancers. Those are the main ones that I can think of. There's more though. There's a lot more. So it's intense, but Joan's a great instructor, and most students who make it through PN2 make it through PN3. This PN2 seems to be that transitional course for students, and it's just as intense as this one. You're going to be pushing on the same rate that we're going with this. Roll and Scope is really an awesome course. It's not as intense as this. And of course, Ginny's teaching it and she's amazing. So most students, as long as they're turning in their work for Roll and Scope, that's the big thing. Don't get behind on your coursework. You can find yourself in trouble with passing if you're choosing not to turn in assignments. That can put you in a bind really quick. So make sure you're getting all your assignments in. Any other questions? Okay, I'm going to stop recording.